we'll do is, so everybody is listening to me? Yes?
Yes, sir.
Yes, okay. So, yeah, so we have been dealing with, we have been dealing with this various chapters in surgery, okay? And uh, so can you understand what, for the last few lectures, so what we have been discussing, can you understand? Yes? Yes? Very.
Yes, sir.
Are you hearing me?
Hazır, sir.
And you can see?
Hazır.
Okay. So today we'll be discussing about enterocutaneous fistula. Okay. So enterocutaneous fistula means, see, actually a fistula is a communication between the two epithelial surfaces. Okay, you know that the definition from the basic sciences. Normal communication between skin with the various part of the intestines. Okay, for example, duodenum, jejunum. Okay, so the fistula actually in Latin means pipe or fluid. So it's actually a pipe-like connection. Okay, and the ileum is the most common site of origin of enterocutaneous fistula. So if you classify enterocutaneous fistula, see anatomical, physiological, and etiological classification. So in anatomical, internal fistulas like enteric fistula, enterovesical fistula, nephroenteric fistula, enterovaginal fistula, enterouterine fistula, aortoenteric fistula. So these are the various types of internal fistula. External means enterocutaneous fistula. And if you see the physiological types, low, moderate, and high output fistula. So see, later when you become more and more senior, so you will be more concerned about the output of the fistula and the types of fistula. Anyway, you will be knowing about it, but you will be mainly concerned for management whether it's a low output, moderate output, or a high output. So if it is low output, less than 200 ml per day, moderate 200 to 500, and high output is more than 500. So you need to remember this classification, physiological classification, according to the output throughout your life. Okay, so remember this. Okay, and then the etiological classification, again the traumatic, that is the most common being the post-operative fistulas, foreign body leading to fistula formation, and penetrating trauma, and infectious, as you have heard about appendicitis. Yes, diverticulitis, which usually occurs in the left side of the colon. So the sigmoid diverticulitis being the commonest. So diverticulum is an abnormal outpouching. So if it is a true diverticulum, the wall of the diverticulum contains whole wall of the intestine. So all the layers will be present. So what will happen is when the diverticulum that gets infected, inflamed, then that condition is known as diverticulitis. So and then it can perforate. So once it gets inflamed, like appendicitis, so it can perforate, and then it can cause a pericolic fistula. So there is a very nice classification about Hinch's classification for diverticulitis. Okay. And appendicitis and actinomycosis. Actinomycosis and tuberculosis are very notorious, causing enterocutaneous fistula. Okay, so these are the actinomycosis being a fungal infection, and tuberculosis, which is the tuberculosis. You will be talked in detail about tuberculosis later. Okay, so tuberculosis of the intestine, so peritoneum. Okay, so these are the causes, infectious causes, but the most common being the post-operative fistula. Okay, so that is the most common, because after surgery what will happen is, during surgery, if some bowel gets injured, so that give rise to some collection in the in the peritoneal cavity, leading rise to fistula formation. Okay, so we come across various types of fistula, which is there. Okay, so during our whenever you, if you become a surgeon later, or maybe a physician, so in that case you may come across various types of fistulas. Okay, and then that will be most commonly the enterocutaneous fistula following surgery. Suppose if you operate a patient which has undergone radiotherapy treatment, and then so after you operate, there will be a lot of dense adhesion between the intestinal walls. So when you are dissecting intestine free from those adhesions, then that can injure the seromuscular layer up to the mucosa, and then what will happen is you don't identify that. So if the mucosa is also injured or becomes ischemic later on, so that gives rise to the perforation, and then that may get adherent to the intestinal, the abdominal wall, and then along the wound of the where you have given an operative when you have operated a patient, the operative wound. So in that, so it can just adhere to that area which part of the bowel is fistulous, and that gives rise to enterocutaneous fistula. It's like that. So that is usually the pathophysiological mechanism where the enterocutaneous fistula takes place. Okay, and then inflammatory, as in the case of Crohn's disease. So the inflammatory bowel disease, that is Crohn's, ulcerative colitis, or non-specific colitis, or viral colitis. So various types of inflammatory bowel disease. So inflammatory bowel disease, which is non-infectious etiology, being ulcerative colitis, and Crohn's disease being the commonest one. So the Crohn's disease involves full thickness of the wall of the intestine. So it can involve from mouth to anal region. So the Crohn's disease is a chronic inflammatory bowel disease which can involve from esophagus up to the anus. But the ulcerative colitis being the rectosigmoid involvement mainly. So if you say the difference, the Crohn's disease will have a rectal sparing effect. So rectum may not be involved in Crohn's, but in ulcerative colitis, the involvement of the rectum is must. So that is the difference. But the Crohn's disease, as it involves the whole thickness of the wall of the bowel, what will happen is that there is adhesion between the two bowel loops, and when you are operating, more chances of injuries. And the Crohn's disease has chances to form the internal fistulas more, enteral fistulas, enterovesical fistulas, enterovaginal fistulas. So that type of fistulas will occur in case of Crohn's disease. So fistulizing Crohn's is a known entity where the treatment is the modality is different. So Crohn's disease. So you will be discuss about Crohn's disease when we talk about inflammatory bowel disease. Okay. So and the malignancies, the various types of cancers like stomach cancers, gallbladder cancers, and last time when we were talking about the gallstone disease, as you have seen the gallstone ileus, so the gallstone eroding the duodenum and the stone migrating into the intestine and getting lodged into the terminal part of ileum, causing obstruction, causing gallstone ileus. So in that case, there is a cholecystoduodenal or cholecystoantral fistula. So various types. And then again, the malignancy of the rectum can cause rectovaginal fistula or the rectovesical fistula, or the rectum can have fistulas with the other part of the intestines. Similarly, stomach and the other types of malignancies. So, and the radiation, I have already told you, the post-radiation, the intestines can get in the internal fistulas or enterovesical fistulas, or after surgery, the enterocutaneous fistulas. So the risk factors being the patient is ill, having some chronic disease, or the patient is in the state of sepsis because of perforation causing peritonitis. So when you operate, the patient is already in sepsis. In those sort of patients, there is more chance of enterocutaneous fistula formation. And then, so spontaneous closure of the fistula can occur depending on the anatomy, etiology. The main is the etiology, anatomy, nutritional status, and how much is the output from the fistula, as we have classified into, as you have seen it, low output, moderate output, and high output. So similarly, depending on the output of the fistula, and related complications like whether the patient has fluid or electrolyte balance, malnutrition, sepsis, local wound excoriations, etc. And etiology is a congenital, is rare, and the enterocutaneous fistula, the failure of obliteration of vitellointestinal duct, postnatal slough of the stump, major penetrating trauma. So it's the trauma, the major penetrating trauma, and the damage control laparotomy techniques for the traumatic cases. So congenital, traumatic, infectious, as I've already told you, and iatrogenic, the post-operative. Okay. So 75 to 85% are iatrogenic after surgery for the small bowel obstruction or the cancer or the inflammatory bowel disease. So the most common being the acquired fistula, being the iatrogenic. Inflammation, radiations, or the tumors, as I've already told you. Infections, iatrogenic, as I've already told you. Okay, so prevention of fistulas. So acute intraoperative perforation. So whenever you operate on a patient, and then in that case you have to identify, because during surgery, otherwise there is a chance of the formation of fistula or formation of post-operative peritonitis. So serosal tears should be repaired. Just a second, huh? Hello. Yes. Okay. So sorry for interruption. As I've attended all the calls from the ward, so I'm sorry for that. Okay, so it's an acute intraoperative perforation, like early identification and closure has to be done, and then the serosal tears, as when you are operating, and there can be injury to the bowel wall leading to serosal injuries. As you know, the bowels have different parts: serosa, then the muscularis propria, and then the muscularis mucosa, submucosa, and the mucosa. So all these layers are there. So when there is an injury to the serosal layer, then you have to repair it, because when there is an injury to the serosa, overlapping is the two bowels will get adherent to each other because of the serosal injury leading to inflammation. So in that area, if there is an intra-abdominal contamination, if you have operated the patient because of some perforation, peritonitis, or some sepsis, then in that case, overlapping is there is chance of formation of fistulous communication. And aggressive adhesiolysis, as you know, that the intestinal adhesions are the main cause of intestinal obstruction. So whenever you do an adhesiolysis, in that case also serosal injury can happen. So yes, whenever you operate on a patient and the post-operative period, there will be anastomotic leak. When you have resected a segment of the intestine and made an anastomosis using the suture material, in that case, if the patient is nutritionally not good and patient has an infection, sepsis, so in that case, what will happen is that whatever you have done, the anastomosis may not take, the thread may give way. The intestine will not be strong enough to hold the thread because of infection. So in that case, it can perforate and form different types of fistula. So the patient will have, again, the signs of peritonitis, fever, abdominal pain, tachycardia, tachypnea, dehydration, sepsis, all features of sepsis. The total count will be raised, okay, and the patient will be, patient will be very, very sick, like a case of a perforation peritonitis. So in that case, you'll know that the patient has the fistula or the perforation. Okay, but if the patient has an enterocutaneous fistula, which is a very low output fistula post-operatively, that may only infect the wound, and patient can develop some fever, but the condition may not be very, very worse. Okay, so it depends what type of fistula it is. Are you listening to me? Yes, tell me.
Yes, sir.
Okay. So again, the different types of internal and external fistulas. So you can see the gastrocolic, jejunocolic, aortoenteric fistula. So intestine having fistulous communication with the aorta, patient will have hematemesis, the blood loss from the stool, and the patient will die if you don't tackle it immediately. External fistula will be gastric, duodenal, jejunal, ileal, and fecal fistula. Fecal fistula is the fistula that is originating from the large bowel. So as I have already told you, this classification. So management is, so this is just some, the mnemonics where I used to use these mnemonics when I was a student. So I've kept that for you. Just don't try to remember only the mnemonics, try to understand it. So stabilization on the patient, sepsis control, skin care, because the fistula will excoriate the skin. And then if it is enterocutaneous fistula, and then the nutrition, the main important thing for healing of any fistula or any patient in the post-op period, the well-being of the patient depends on nutrition of the patient. Anatomical identification of the where exactly the site of fistula, and plan to deal with. So once you know the exact site of the fistula, where it is coming from, then it is easier for us to manage the patient. How, and then our management differs according to the site of the fistula. Stabilization, this you learn over the period of time. So so you resuscitate the patient with you open an IV access with a wide bore cannula, and then resuscitate the patient with IV fluid as the patient is not able to take orally because the fistula is there or the patient is having features of sepsis. So you have to give IV fluids, antibiotics to control the infection, send the culture from the fistula site or from the abscess cavity, send the culture for culture and sensitivity, and see the antibiotic. You can change the antibiotic later on, and you have to protect the fistula tract, the surrounding skin, because the bile is very, very toxic to the skin. So you have to apply some ointment or some paste like zinc oxide, which will not let the bile to come in contact with the skin and prevent from excoriation. And measuring and replacing the ongoing growth. So if the patient is passing urine, patient is passing stool, and the fistula is also the low output fistula, and patient is not, or a high output fistula, and then the patient is not taking orally. So input and output, total intake of the patient and total output of the patient. So you have to take in consideration the urine output, the stool output, and the fistula output. So that much you have to replace through IV fluid or through orally or through total parenteral nutrition. So through IV access. Okay, so you have to monitor all those things, see the urine, so you don't let the urine output fall down because of inadequate the intake or IV supplementations. The patient will go into dehydration. Okay, so that will give rise to renal shutdown, and then again the patient will go into renal failure, the renal insult due to infection as well as inadequate IV fluids. So you have to take care of the intake and output. Resuscitation, I already told you, you just remember that, and you have to monitor the urine output, and then you have to see the electrolyte imbalance, because if there is a high output fistula, a lot of potassium will be wasted, the patient will have hypokalemia, hyponatremia. So you have to supplement the IV fluids and add additional potassium KCl, potassium chloride in the IV fluid, and then the sodium supplementation. And then so you have to see for the, mainly what you have to understand is you have to control the infection, and then look for the intake output chart, and then you have to do how much to give and what is the output, and then you have to balance the fluid and electrolytes. Electrolytes has to be balanced, so you have to supplement, then you have to supplement, and then the trace elements and like zinc. Okay, so magnesium, zinc, okay, this has to be monitored, and then it has to be supplemented. And the urine output must be 0.5 ml per kg per hour. Remember this statement for your lifetime. The minimum urine output which has to be maintained for a normal individual is 0.5 ml per kg per hour. If the patient is in sepsis, better to monitor, better to keep it at 1 ml per kg per hour. So 0.5 ml per kg per hour will make it 30 ml per hour. So this you have to remember. Minimum 30 ml of urine has to be there. Nutrition, as I have already told you, whether you can give an enteral nutrition, that is through the mouth, or you have to give an parenteral nutrition, because the nutrition is the only factor that will give the fistula energy, that you will give the fistula all the necessary thing to build up the to contain the inflammation and then heal the wound. So nutrition is the only thing, and that will give you the immunity also. So nutrition has to be there, and hydration, that is the total fluid and electrolyte balance, has to be there for all the fistula patient. Maintain the nutrition, whether through parenteral route or through oral route, and then you control the infection and then maintain the intake and output. So low output fistula, see the kilocalories requirement 30 to 35 per kg. As you and me, we require around 2000 kilocalories per day if we are not doing heavy work. But if you see this, so if you 30 to 35 kilocalories per kg per day, and then the protein requirement and high output fistula, again you have to give around 45 to 50 kilocalories per kg per day, and then the protein requirement and the trace element like zinc up to 10 times the daily requirement, and the vitamin C and the magnesium. And the mortality rate is 42%. See, if the patient nutrition status is bad, then the albumin will be less than 2.5, and then see the mortality is 42%. Out of 100, 42% of the population will die if the albumin is less than 2.5. So that means the nutrition is poor, because the patient is throwing all the nutritious thing to the fistula, and then if you are not supplementing it properly, then what will happen is there will be high mortality, and then 0% which is more than 3.5. So control of sepsis, okay. So the problem is that, see, this already I have told you about the different signs and symptoms and the investigations and the protection of the skin, okay, and the IV fluids. So you can see the various types of fistula and the various types of vacuum assisted closure dressing has been applied. You can see the two pipes going through the plastic coverage, which is also known as a vacuum assisted dressing. It is a specialized equipment, not only made of plastic, but there are so many other things which has been used. So you can see then how the fistula wound, the big wound initially, which is healing one after another. So the first one is the initial status, the second, third one is the dressing has been applied to the fistula, and then you can see it has been shrunken in size in the D, and then again it is E, it is more shrunken, and in the F it is healed. So you remember, this is vacuum assisted closure. Vacuum assisted closure, VAC. It is not only used for fistula, it is used for chronic wounds also, okay, diabetic foot and all sort of wounds. Pharmacological support, yes, you read about it, okay, because as we are giving antibiotic, that is also pharmacological support. We are giving proton pump inhibitors or S2 receptor antagonist, okay, and the somatostatin and the octreotide, these effects is controversial. But if you use somatostatin, reduce the secretion, the pancreaticobiliary and the intestinal secretion will be significantly reduced. But whether it will help in the fistula healing, nobody knows. It is controversial, but still people use it if it is a proximal fistula or if it is a pancreatic fistula. So investigations, as you know, that the X-ray and then to locate the fistula, and ultrasound, fistulography. Okay, so through the fistula tract, you inject some dye, okay, contrast, and then you see where it is coming from. And nowadays, the CT scan is the very highly recommended, and depending on if it is an anal fistula, perianal fistulas, not an enterocutaneous, just the perianal fistulas, then in that case, the MRI, fat suppressed image for perianal fistulas, they are diagnostic. It will locate the site and the length and the openings. But for enterocutaneous fistula, CT scan is the best, using oral and IV contrast. Okay, and the fistulography, if the fistula is quite long, and then it will tell you about the length and the width of the fistula. And ultrasound will tell you about the abscess, and it can help to aspirate. Okay, and then X-ray will tell you about the foreign bodies. This is a fistulogram where we have injected the dye from the enterocutaneous fistula, and you can see the cavity, the fistula's track, and where it is going into the small intestine. Or maybe this is a cavity. Where there is a cavity, there is an abscess, and then you inject the dye from that, and it is going into that abscess cavity due to fistula. So definitely there is a fistula, intestinal fistula, which has formed initially peri-intestinal area. The collection is there, which has formed an abscess, and it is coming out through the skin. So when you inject the dye, it did not go into the intestine, and it is going into the cavity only. So that may be in this case, but you can see how nicely the fistula is seen. So decision depends on the site of the fistula. I will not go into that. The only thing is that if you see the 6th point, so there is in the 6th point there is called distal obstruction. Output I have already told you. Output I have already told you that the favorable output is if it is a low output fistula. Unfavorable is it is high output fistula. So for the patient and for the doctor also. But if the state of the bowel, you can see the distal obstruction. Suppose there is an ileal fistula and there is obstruction to the large bowel. So in that case, the fistula is not going to heal. Okay. So state of distal obstruction. Suppose there is a ileojejunal junction fistula and there is obstruction in the distal ileum. So in that case also, this fistula is not going to heal. So that is an unfavorable situation. So distal obstruction. So whenever we talk about healing fistula, in a situation where there is no distal obstruction, is good. So whenever we do a discussion, okay, what are the factors in favor of healing of fistula? Then we'll say that, okay, low output, good nutrition, okay, distal obstruction is absent, sepsis is absent, the track is less than 2 centimeter, defect is less than 1 centimeter. That's good. Okay, so it's good. If it is more than 2 centimeter, if it is more than 1 centimeter, then it is bad. Okay, so similarly, the nutritional status and the distal obstruction. Remember this, distal obstruction is bad for the fistula, the proximal fistula, and the nutrition and the sepsis. So, as you know, the factors responsible, I've already told you, friends, you can say. Foreign body radiation, inflammation, infection, epithelialization, neoplasm, distal intestinal obstruction, and steroid, use of steroid. See, use of steroid will also give rise to non-healing of fistula. So steroid use is very, very crucial. Sometimes it is very nice to use steroid. Sometimes it can be hazardous if long-term use of steroid. For example, in case of inflammatory bowel disease, they use a lot of steroid and the patient will have poor healing, and that sort of patient, if have to go operation, in that case, then you will face a big problem of the patient going to die, or patient may not recover well. It will take months to recover. So use of steroid for a long time can be disastrous for the surgeons. Okay. So this is a summary of all the things which we have said. Okay, so see, initially recognition of enterocutaneous fistula, so local control of the fistula output, control of infection, resuscitation for about 3 days. Stable patient free of clinical signs of infection, then nutritional support, you are given a total parenteral nutrition. Total parenteral nutrition is a bag containing lipids, okay, and then calories, proteins, that in the form of amino acids. So the bag is there, white, that contains whitish fluid inside. It is a sterile thing which is manufactured. You can buy it like an IV drip. Okay, so and then you can give it within 24 hours. Okay, so through the central line, you cannot give through peripheral line. Okay, so there are some form of peripheral TPN also, but mainly you go through central line. So 5 to 7 days, patient doing fine. Okay, good. So you give nutrition, put the patient on good nutrition supplements, and then if everything is good, and if the fistula is healing, then no surgery is required. Around 12 weeks it will heal. And if it is not healing, the output is going more and more, you are giving good nutrition, but it is not healing well, wait for about 2 weeks. Okay, then if it is not going down, then you may have to undergo surgery and close the fistula. So, okay, 80 to 90% will close with treatment. You can see the 6 weeks, in 6 weeks time. Okay, and this 6 weeks is a very magical word for surgeons. Acute cholecystitis, operate immediately or operate after 6 weeks. Okay, and in pseudocyst of pancreas, after 6 weeks, pseudocyst will mature. Okay, 6 millimeter is the size of the common bile duct. Okay, 6 millimeter stone will pass through the ureter. Okay, also for fistula, there are other 6 also, I'll tell you later. So in fistula also, you wait for 6 weeks. If the output is decreasing, then it's all right. If it's not decreasing, then you have to operate. Okay, that's, I think, so the basic principle of surgical treatment is you have to explore it, find out the tract, where it is there, do an adhesiolysis, and then if it is possible, refreshen the tract which is connected to the intestine, or you may have to do a resection anastomosis. So enterocutaneous fistula, as I have just put up some pictures which may be very confusing for you. Okay, so just don't remember these pictures. Enteroenteric fistula, yes. Sometimes you may not notice enteroenteric fistula. You don't know it. Later, patient will come with small bowel obstruction or large bowel obstruction. So when you are operating on the patient, because of some other reasons, you may encounter a place where there is already an enteroenteric fistula is there. You will see these sort of cases when there is a patient which is suffering from Crohn's disease who comes with intestinal obstruction. Okay. Enterovesical fistula. So enterovesical fistula is the intestine is the communicating with the bladder. So what will happen is the patient will have, when he is passing, he or she is passing urine, that they will pass air or the fecal matter through the urine. And then patient will have fever, chills and rigor, and the patient will come to you and he'll say that I'm passing air through my urine. Okay, or sometimes some flakes like thing come. Oh, then you'll think, okay, this could be an enterovesical fistula. Okay, then you will investigate the patient. Maybe you'll do a cystoscopy and try to isolate the site of the fistula, or you do a contrast CT scan and then you will see the location of the fistula. Oh, there is a fistula. Then you have to open the patient, operate on the patient, and you have to operate on the patient. And what will happen is once you operate, then you locate the site of the fistula tract, and then what will happen is you will excise the fistula tract and close both sides of the bowel and the bladder in layers. So that sort of thing. Enterovesical fistula, very, very nasty situation. Enteric fistula, very rare. I'll not go into that. And enterovaginal fistula, very common. So sometimes through the vagina, they will say some fecal matter is coming. Okay, so in that case, again, the same thing. You have to do contrast studies, contrast in a CT scan. Do similar to the colposcopy you can do, similar to the cystoscopy. You can look into the vagina and then look for the site of the opening into the vagina, that is a fistula tract opening that you can identify, or you inject some dye and then see whether the dye is coming into the vagina. Okay, so or from CT scan, then again you have to repair the vaginal wall, and then you can do again the fistula repair by open surgical technique. So aortic enteric fistula, will not go into that. It's an emergency situation where there is high mortality. Okay, so very difficult to treat. So enteroatmospheric fistula, that means that it is not connecting to the skin. You can see here the bowel wall is there. There is a fistula opening there, and then it is into the atmosphere. So the fistula opening is there. From there you can see that spot here. So this is coming here. So this is the bowel wall. This is the fistula. So from here the enteric content is coming. So there is a vacuum assisted closure is done, and then you can see here it has been healed. Okay, so slowly there is a epithelialization of the superficial part, and then it has healed and it is closed. Very tricky situation. This patient can have problem anytime. Okay. Okay. So there are various surgical techniques. I'm not going to detail that. You learn it later. Okay. So in conclusion, the enterocutaneous fistula are abnormal communication